Can I just ask a quick question? Are we gonna, is the flow gonna be, we're gonna introduce ourselves, kind of explain our roles in the birthing process, and then open the floor up for questions, or how do you envision the panel going?
Yeah, I was just going to introduce you guys briefly, and then everyone's going to have 10 minutes to talk about the work that they do and the role that they play within the birthing team in the hospital, and then how that work and that role is really fundamental in maternal and fetal birth outcomes. And then that should be around like 40 minutes, and then the last 15 minutes are open for questions and answers.
That sounds great. Hi, Kiara, long time no see.
I know, it's nice to see you in this space. Just saw you a few hours ago.
No, we just did a C-section together. Well, very cool.
Nice to see everybody.
For sure.
Well, Kristen, we have to connect too. I got some information about that program that you had just completed too.
Okay. Yeah, I'd love to chat with you about it. It's fantastic.
Perfect.
Okay, I think we can start. There might be a few more people joining at around 7:30, just because another event is ending at around that time. But I want to thank everyone for coming today, and especially our panelists for taking the time out of their busy days to talk to us about working in a birthing team and all the important work that they do to support mothers and babies. So on our panel, we have Dr. Lindsay Snyder. She is a fellow of the American College of Obstetrics and Gynecology. We have Allison Tran, a certified nurse midwife. Kristen Revere from Gold Coast Doulas, a doula agency that works closely with Corewell Health now, and Kiara Baskin, a doula with Day One Doula Collective, who also works closely with Corewell Health. So really excited to hear from you all. If anyone wants to turn their cameras on, feel free to. No pressure, it's been a long day. But if you're so inclined, we'd love to see everyone's faces. And if anyone has any questions, you can drop them in the chat, or you can message them to me and I can read them out loud during the Q&A session. So whenever we're ready to begin, Dr. Lindsay Snyder, whenever you're ready, you can talk a little bit more about the work that you do.
You're muted, Dr. Snyder.
I apologize. Can you hear me now? I'm Dr. Snyder. I am an OBGYN. I'm also, so I kind of serve a few different roles at Corewell. So my sort of journey started when I was an undergraduate. I was always really interested in women. I'm one of 4 girls in my family. I always felt really comfortable around women. Was almost a women's studies major. So it was really, I was just kind of really passionate about taking care of women, reproductive justice, things like that. And so that's always kind of been a love of mine. And so then when I went to medical school, I'd always thought maybe OBGYN in the back of my mind, because that's kind of where the experts in women's obstetrical and gynecological care. And then I was a little bit, I would say, fearful of residency, OBGYN residency, just because it is a surgical-based specialty. So it's pretty intense. So it's 4 years of medical school, obviously where you guys are, and then 4 years of residency. And I trained at Beaumont over on the east side of the state, now Corewell Health East, in their main kind of Royal Oak mothership. So 1,000-bed hospital, almost 8,000 deliveries a year. So very comparable to Corewell. So I trained there. I went to DC for about 7-8 years. I was in an academic faculty at GW in DC, and then I was in private practice for several years outside Georgetown. And then I was sort of pulled back to Michigan. I'm from Ohio, but we have a family home up on the lake north in Ludington. So I kind of got pulled back here, and my husband also was recruited. He's a medical malpractice attorney. So he's actually works for MPI, which is the medical insurance carrier for Corewell, Sparrow, a lot of major medical systems within the Midwest, Michigan, Indiana, that kind of thing. So, yeah, we came here, and I have 3 kids, so I'm kind of juggling, doing that, juggling profession with mom and being a wife and all that stuff. I would say, as far as kind of ultimately what made me go into OBGYN was that I really tried hard to talk myself into an alternative like family practice with an OB emphasis or internal medicine. There's actually women's healthcare track, so you can actually become a internist, but kind of with a specialist in women's healthcare. So you would be trained to do colposcopies and paps and all that kind of thing. But I think what ultimately drove me back to OBGYN, and I kept kind of coming back to it, was I wanted to be the expert, right? Like I didn't want to be refer anything out. And I also felt really strongly that if I was going to be delivering babies, I wanted to be able to get the baby out, like via C-section if I had to. I wanted to kind of didn't want to defer to anybody else about that. And so, and if you're an MD, that's kind of the path, right? And so for me, I was very committed to kind of becoming an expert in gynecological surgery and obstetrical care, encompassing all of that. So that's ultimately, I think, what drove me to OBGYN. The residency was challenging, I'm not going to lie. Probably after general surgery, it's probably one of the hardest residencies. So it's not for the faint of heart. But I think ultimately, if you are, kind of like that blend of it's kind of obviously women's healthcare, but then also the surgery. So we are surgeons by nature. So, if you love the ORs, you're kind of going through your 3rd and 4th years. If you can't imagine not being back in the OR, if you like that, then OBGYN is a great choice because that kind of is a blend of everything. I would not say that we're primary care doctors, specifically as things are kind of diverging and getting more niche-y, if you will. I don't manage cholesterol, high blood pressure, all that stuff outside of pregnancy. So I don't, we kind of sometimes can do some well women visits within OBGYN office, particularly in your reproductive years. But really, I kind of defer the overall management of those diabetes, high blood pressure, things like that to primary care doctor, whether that be family practice or internal medicine. So yeah, that's kind of my story. I don't know if that's 10 minutes, but so who's next?
Yeah, if Allison, Tran, if you want to talk about the work that you do and then your interactions with Dr. Snyder, I know that you guys work closely together.
Yeah. So hi, I'm Allison Tran. I am a certified nurse midwife that I work at Corewell with Dr. Snyder. I've been there about 9 years. So my path was a little wandery, I suppose. I actually started off in a combined undergrad medical school program at University of Michigan. Wanted to be an obstetrician from the time I was 10 years old. Like that was always the plan. And then I actually met some midwives and I was like, this is what I thought obstetricians did, which was not what they actually do. So I really liked being at the bedside. I liked spending time with women. I liked that continuity. So I kind of changed my path. I ended up getting a degree, just finishing up my bachelor's. And then I went out to Baltimore and got a nursing degree. And then I came back to U of M and got a midwifery and a nurse practitioner degree. And I worked at a federally qualified health center in Muskegon, taking care of Medicaid and uninsured women for several years, which I really enjoyed. We got to practice to the full scope of our license. So I got to do colposcopies. I got to do all those kind of well woman visits on top of the prenatal care. We first assist on C-sections, so that was great. So I felt like I still got to do some of those little things that I always wanted to do, but also I had probably twice as long as my physician partners to spend time in the office with patients. I would go in as soon as it was admitted in labor, as soon as their water broke, and spent, the entire however long it would be with them. So I was there for a few years, and then I got recruited into a private practice, which was more of a bougie, if you would, higher income, higher educated people looking for midwifery care. And that was much more patients looking for water births, patients coming in with doulas, patients who really were seeking out midwifery care. And I really enjoyed that, but it is very, I guess exhausting is the best word when you're going in and you're laboring with someone from the time their water breaks to maybe 48 hours later. And then I would, again, get to first assist. So if I had to turn them over to my partner for a C-section, just like Dr. Snyder's referring to, I would get to be there and be supportive. And that was great, and participate in the surgery. But it just was kind of a lot. I have 4 kids, so similar thing, trying to balance work and life and being around for your children and not getting pulled in on call every time you're trying to hang out with your family. So for the past 9 years, I've been at Corewell, and my role there is very different than sort of the traditional midwifery role. So we have the midwife team that's part of the core faculty that works with medical students and works with primarily the intern residents, sort of teaching them that basic bread and butter, sort of low risk obstetrical skills. So how to deliver babies, how to do basic repairs, how to check cervixes, how to do speculum exams, kind of those, the basic skills that you need to be an obstetrician or a gynecologist. But I don't have that continuity that I had in private practice. So I don't have patients where I've delivered 2 or 3 or 4 of their kids that I see. Most of my patients, because I don't do any outpatient, I'm a hospitalist. I meet when they come in for labor, or maybe meet an OB triage, and then get to take care of them. What's really great about what we do, though, is we are a team. So we have midwives and physicians that are there together all the time with the residents, kind of wrapping around the residents, and they can learn how to do lotus births, and they can learn how to do C-sections and complex gynecological surgery with the other doctors, right? So they get that whole broad spectrum of education, which I think is great. And I think it's great for our patients. We have something we call it the high touch, low tech room. So it's a room with a big queen size bed and no monitoring equipment in there. And it's just a much more homey sort of atmosphere. So we can offer that. Plus we have our level 4 NICU, which is a really great thing to be able to be a part of. And I get to take care of patients that probably most midwives don't get to take care of, because I have my partner physicians like Dr. Snyder that are there with me all the time. So they're in-house 24/7. So I can bounce things off of them. We can flow back and forth. If they're in the operating room, I might watch their high-risk patients for a while. It's just a really nice sort of ebb and flow and continuity with the patients that I think is something great that we have. I think that's all I have to say.
Thank you. I actually had a question for you. You had mentioned that midwifery seemed a lot like what obstetrics does. And I think, I mean, for me, and I'm sure for other people, when you described it, it really does sound a lot like obstetrics work. So I'm not sure, could you expand, and maybe Dr. Lindsay, you can jump into about the differences between midwifery work and traditional OB-GYN work?
I think a lot of it is going to be the risk of the patient. So midwifery traditionally takes care of lower risk patients. So I don't do multiples. I'm not going to do breech births. And this is not all midwives. This is what I do and what I consider safe to do. We do VBACs, or trial of labor, TOLACs, trial of labor after C-sections at the hospital where I work, because we have anesthesia, we have surgery, and because I have physicians there. When I worked at smaller hospitals, I didn't do that. So I think that's the main thing, is the low risk versus high risk. And again, so I first assisted on C-sections. I helped out the doctor who's doing the surgery, so I could continue to participate, not feel like I had to hand off my patient, but I can't do that on my own. I need a physician there to do that with me. But I think what I guess I meant when I said that is sort of the picture that I had in my head growing up and seeing obstetricians on TV or reading, the picture I had in my mind of the lifestyle or the relationship they would have with their patients once I got out, I realized that was more midwifery was what I was actually picturing than obstetrics and gynecology, if that makes sense.
And also to kind of piggyback off what Allison is saying, she's absolutely right. So we actually sit down every day when we, flow back and forth with our midwives in residency, and we kind of stratify people or patients into like high risk, low risk, medium risk. I will say this, we have a wonderful collaborative practice with our midwives. It's very much, I would say, a dyad approach. It's not, I'm above Allison or Allison's above me, anything like that. I think it is truly more of a partnership. And so I think that, we are very comfortable saying, hey, is this too high risk for you? And our midwives do a incredible amount of what I would consider probably high risk pregnancies, just because they quite frankly have to. We serve a very underserved Medicaid, almost 100% Medicaid based population. And so, as we all know, the population is getting more acute. We're just seeing skyrocketing rates of obesity, diabetes, high blood pressure and stuff. So we are really moving away from kind of those low risk patients, just because almost everyone has something that they're bringing to the table. And so our midwives, I would argue, really operate at the top end of midwifery care. They also have, I would say, a more holistic approach, if you will. I think they, quite frankly, have they counsel patients better in terms of their, like, for example, postpartum care. Kind of going back to what I said about, like, I'm a surgeon by nature, right? So I'm very much like, kind of in and out. Efficiency is kind of the highest thing, right, in my mind. And our midwives really do a fantastic job of kind of holding the patient's hand, really walking them through, pushing with patients, things like that. So I would say it's not better or worse, it's just a different approach. And the demand for midwives is increasing. So I think what's really nice about our practice is that I feel like it's the best of both worlds, right? Like, our patients have awesome midwifery care if it's available to them and they want it, if they are, meet a certain risk category. But on the flip side, if they're multiples, need a C-section, things like that, like Allison was saying, I'm there. So it's kind of a really nice balance, I would say. Allison, do you think that's the best word? If that helps, kind of, because I know obviously a lot of we're MD in training, right, in the room. So just kind of, so you can kind of gauge. But again, I would say it's a very collaborative practice. And I think there's a mutual respect that is there. We have different skill sets. And so I think that, yes, even though we're both delivering babies, I think it's also a different approach, if you will.
Yeah, I really appreciate that from both of you. That really helped clarify things for me, and I hope for other people. And it was really beautifully said. So thank you. So now we'd love to hear from Kristen Revere from Gold Coast Doulas.
Hi, everyone. I'm Kristen Revere, and I own Gold Coast Doulas. Started the agency in 2015, and we are a full-service doula agency. So basically, from conception through the first year, we have a variety of classes and services, including birth doulas who do work in Corewell Health, and we teach classes everything from breastfeeding to hypnobirthing, and we offer bed rest support in home or in hospital. And we have, our core focus is day and overnight postpartum support, especially the overnight care. We work with a lot of twins and triplets, babies coming home from the NICU, and anywhere from one night to a year. We work up to the first year, and then we have a team of 3 certified sleep consultants that do virtual services as well as in-person implementation. And our office is in Easttown. And yes, we do partner with Corewell in quite a few ways. We've been part of the Spectrum Lead Giving, the foundation, the Women's Giving Group, for multiple years. And yeah, as far as my path to becoming a doula, I've been a childbirth educator for 10 years. So right after my son was born, I got into teaching, and then my students wanted me to become their doula as we bonded in these 8-week classes. So I went to Florida and got trained to be a doula, 4-day training, and went through the certification process, and then went on to get certified through another birth doula organization. And I've been a certified postpartum doula for over 7 years now. And my background is in political fundraising, nonprofit fundraising. So I did a lot of that work in tandem with owning the business for the first 3 years, and then went full time after that. But I worked with both OBs and nurse midwives during my 2 pregnancies. My daughter's 12, my son is 10, and I have a stepdaughter who is 21. And so, yeah, so I've experienced both. I ended up with preeclampsia with my first, so I had some co-care with OBs and was induced at 39 weeks, had an unmedicated birth and outside of the Cervidil induction. And then with my second, I hired doulas. I found out about doulas. My kids, of course, are close in age, so the call to the doulas was one of my first calls. And then I had, in a pretty easy pregnancy the second time around, did not develop preeclampsia. So I just became very passionate about women having support and resources and, access to all the services that they need. And so, yes, our clients essentially, I'm not sure how many of you know about doulas, or if you wanted me to define the role of a doula and how we work with obstetricians and also, nurse midwives and labor and delivery nurses.
Yeah, I think that'd be wonderful. I know that I'm aware of doulas just because I did volunteer as one for some time, but I think overall they're a fairly new phenomenon in US hospital systems. So I think it'd be really great to go over their roles and their partnerships with midwives and OB-GYNs and other healthcare workers.
Okay, sure. So doulas are non-medical support. So we take more of a coaching role and defer all medical questions throughout pregnancy or during the labor to the medical team. So doulas support in 3 primary ways. One would be physical support, and that could be position changes, labor massage, hip squeezes, counter pressure. Again, to that emotional support and the coaching, however they choose to prepare. And then we also support partners emotionally and with resources. And then again, with information, both in pregnancy and during their labor itself. If decisions need to be made, we can give them some evidence-based information. But of course, that conversation is between the client and the provider as far as decision making goes. So we do support from the moment a client hires us, which could be very early in pregnancy or could be right before delivery. We have some clients that call us, a week before their due date. And so some connections are very strong and others we attune quickly to. And, my goal as a doula is to, work with everyone in the room, whether it's, the partner or the client's mother to the nurse, to the midwife or the OB as a team member. So it's all about collaboration.
Wonderful. Thank you so much for sharing.
Sure thing.
Yeah, and I'd love to hear from Kiara Baskin from Day One Doula Collective as well. I know that you work particularly to reduce disparities in maternal health outcomes and fetal health outcomes in underserved populations such as Black populations and immigrant and non-English speaking populations. So we'd love to hear more about that.
Yeah, absolutely. So I'm Kiara Baskin. I am the executive director of the Day One Doula Collective program. So Day One Doula Collective, and you'll see me glance at my notes over here. but really is a two strategy systems level response to the inequities we see specifically around low birth weight, and really the need to diversify the healthcare system. So our first strategy really focuses on connecting women of color, specifically in Kent County, to other women of color who may be at risk of having a low birth weight baby. And then our second strategy is making sure that we are training and equipping women of color within the Kent County area, specifically with the skills and certifications that are necessary to achieve a career pathway as a doula, and ideally earning a sustainable wage. So the overarching goal is really to increase the likelihood that women of color are having a baby that is over 5.5 pounds. So talking about our mission, so kind of covered that our doula mission is to recruit, train, and support people of color as community-based doulas. And I'll define kind of the difference between a private practice doula and a community-based doula, because there are some slight differences with that. But we're supporting families throughout their full reproductive experiences. We really have some strong core values, making sure that we're inclusive, that we're providing affirming support, that we have a collective mindset. We were really intentional in naming our program as a collective because we believe that it takes all community to really address the inequities. And we want to see our community pour in and for us to pour into them as well. So just briefly sharing a little bit about my background. So I am a certified doula and certified lactation counselor, born and raised in the Grand Rapids area. So I live and serve my same community. I do have my own private practice, Bump to Birth Doula Services, but it's really been my passion to serve other women, specifically within my community. Talking about what is a community-based doula. So like Kristen mentioned, we're providing, that physical, emotional, and informational support to families. But specifically as a community-based doula, most of us live, work, play, right within our same communities. And if any of you are familiar with the social determinants of health and health equity and health disparities, I'll speak a little to that in the next slide. But that is so important to be a part of your community, to live within your community and serve your community. There's a different level of trust and care that we have when we're working with members because they know that we're right in their neighborhood. Some of the services that we do provide with our doulas is comprehensive birth planning and education, providing emotional support, assisting with comfort measures for pain relief, assisting with birth coaching and sometimes advocacy. We do a lot of work with Corewell specifically. I sit on their diversity, equity, and inclusion space, but partnering with them in ways to make sure that our community voice is also heard at some of those tables. And then we also offer postpartum support and recovery during those visits. So like I mentioned, what a community-based doula is a community worker who provides support during, before, during, and after childbirth, but really making sure that our members of our community have a safe and empowering birthing experience. We do typically work with underserved communities, so about 90% of our clients are on Medicaid or are Medicaid eligible. We meet our clients several months before birth. Sometimes we meet them same day. The client that I had the pleasure of serving today with Dr. Snyder, I met maybe a week ago through an email exchange, but today was our first time meeting in person. But you would never guess that we hadn't known each other. And that's just the beauty of the work that we do. We get to meet these beautiful people and really help to usher their new baby into an environment that feels safe, where they feel seen and feel heard. And it's probably one of the best things that I've ever had to be a part of, is really supporting these other folks. But we develop these relationships with our clients, and we discuss a range of topics from birth to breastfeeding and bonding with baby, but also making sure that our community members are aware of different resources in community. So we partner a lot with Moms Bloom, which is a postpartum organization here that's serving Kent and Ottawa County. So we make sure that our families are connected to that service so that they have postpartum support. We make sure that our families are connected to local breastfeeding groups. So if they do need additional support with lactation, they have a space where they can go and convene. So a lot of that is the work that we do. So talking briefly about why doulas and why now, especially having a collective that's particularly for Black and or women of color. We know that access to continuous labor support from a doula is especially vital for birthing people of color. We know that Black birthing people experience higher rates of poor birthing outcomes, including higher rates of cesarean sections, preterm birth, low birth weight, and infant death. This data is a little bit dated, but looking at local data, specifically in 2018, Black babies were still more than twice as likely to be born at a low birth weight or die within their first year in comparison to their white counterparts. We know that we are making great strides in addressing health disparities and making sure that, our society is equitable for all birthing people, but there's so much work that still needs to be done. There's so many conversations that still need to be had, and it does take community to be able to address all of those issues. Doulas are just but one piece to this amazing, journey towards having a truly equitable society. And I like to bring that up because right now, you may have all seen that doula services are now a reimbursable expense under Medicaid. And while that is great, and while that provides a lot of access to a lot of people who otherwise would not have it, again, doulas are just but one piece to that puzzle. We need to talk about all of the safety net services that are needed for families, talking about the infrastructure that's needed for doulas to actually be able to do the things that they need to do. We don't have 24-hour child care centers where, our community members can drop off their babies, or doulas have access to that. We kind of built that into our programs or into our structure. And Kristen can speak to this too, about having backup doulas to be able to support one another. But what would it look like if our society just had that already built into the infrastructure, making sure that doulas and healthcare providers are connected to mental health services. Oftentimes we're going into these birthing spaces and supporting people with all of the things because they're coming with everything. And sometimes we take on some of that trauma, and we need to be able to, care for ourselves. So we do a lot of advocacy around that and making sure that not only are doulas having access to care and services, but our families and community members as well. I won't bore you with the data, but I do want to just talk about some of the community partners that we work with as well. So we've done some work with the Center for Study of Social Policy. Our program is housed at Baxter Community. We are our own separate program, but what a great opportunity for us to be housed right within the urban core of our community. When I talk about safety net services, Baxter provides so many wraparound services for our families. So we get them prenatally, we work with them through their birth, but their child has access to well care visits at the Baxter Clinic. There's dental at the Baxter Clinic. There's a child development center at Baxter Community Center. There's a marketplace at Baxter Community Center. So everything that you need for your family is under, this one roof. So we're really happy to be there. We partner with Strong Beginnings and making sure that our families have support beyond that first year. Strong Beginnings works specifically with women of color to make sure that they have a community health worker that's walking alongside their families up to 2 years. We partner with K Connect. Our program was actually born out of K Connect and their prenatal to third grade work group. We do some partnership with Mercy. We're building our relationship. Everybody has a new name, so I apologize if I'm using their old names. Trinity Health West, I believe, is the new name. And then we're also partnering with University of Michigan West. But yeah, we are doing some amazing things in community as far as our training program goes. It is a 15-month commitment for our doulas. It's 2 parts, so they get 12 weeks of classroom training and then 12 months of hands-on client work. And the reasoning why our training program is as extended as it is that we know that we're asking Black women and women of color who have historically and are currently still serving in a caregiving role to then go and care for somebody else. So we also need to make sure that we're pouring into them and providing them with care and mentorship and opportunities to have, someone walk alongside them through their journey while they're walking alongside our community members. Outside of the classroom component, our doulas are then required to provide support to 5 families. They are doing prenatal visits, labor and delivery support, and then providing postpartum support to those families as well. So they have a really extensive, just kind of knowledge base, and just some great opportunities to partner with some of our partners as well to get some more hands-on work in all different aspects of birth work. And as far as our eligibility requirements for both participants who are seeking doula services and those that are looking to train as a doula with our program, we just ask that, you know, our participants live within Kent County. Like I said, it's important for us to live and serve right in our own neighborhoods and communities. For our doulas, we do ask that they're at least 18 years or older. There's a lot of heavy things that happen in birth work sometimes that we don't necessarily expect. And I know that birth work oftentimes can be very romanticized. So we try to provide our community members with some of the realities and some of the beautiful moments that we get to experience as well. And we often see that if we have a little bit of an older demographic participating in our training, they're a little bit more equipped to handle some of the things that we are faced with. And then we just ask that folks identify as, you know, a marginalized group. So whether they identify as Black, Brown, or Indigenous, but we welcome anyone at any stage. There's no gestational age requirement. And it's really just a great opportunity to be able to serve our community and have so many amazing partners and so many great working relationships with our healthcare providers. So that is us. Thank you.
Wow, thank you so much for sharing. That was really robust, and we really appreciate you talking about the community and all the partnerships that it takes to really create an envisioned birth story, right? Because not every birth story is perfect or beautiful, but it is envisioned. So really appreciate you sharing about the work. And to all the panelists, appreciate the time that you've taken and the stories that you've shared about yourselves, about your work, about your patients. So we're gonna open it up for any questions. I know I have a list, but if anyone else wants to start us off, I'll stop talking for a minute.
One thing I just wanted to kind of echo what Kiara was saying. I read a really interesting article recently that kind of talked about the shift in obstetrics from home to hospital. And up until 1930s, you know, most people gave birth at home, typically, you know, by a midwife, right? And specifically to kind of what Kiara's point was, it was a midwife in their community, right? Someone they trusted. So Black communities frequently had kind of a designated midwife, right? And so different communities really had that trusted person that would attend these births. And that changed, you know, in the 1930s, there was kind of this push to get into the hospital. OBGYN, you know, was kind of coming on, and really the move away from sort of that home community-centered midwifery, you know, based care. And I think what's really awesome about what our doulas are doing is just really being an advocate, I would say, for the patient, kind of at the bedside, in the community, sort of providing that support. I cannot emphasize enough the impact of psychosocial, you know, determinants of health. Frequently, many of our patients, our BIPOC women, bring, quite frankly, quite a bit of generational trauma to the table. And like Kiara and Kristen were saying, it's a lot. It is a lot to take in. And so I think that I love that we're kind of bringing some of that back, kind of that support, that local support back for these women. We know that maternal mortality among Black women is 3 to 4 times higher than that of a white woman. And why is that? Systemic racism, right? And so I think that every little bit that we can kind of chip away at that and really change how we approach things. I have definitely changed the way I practice, you know, and Allison can probably speak to it too, but I think just those are some pretty sobering facts. And I think we all kind of as OB providers really had to step up to the plate and kind of take a step back and be like, wow, that's on us, right? That's that we own that. That's not on the patient. And so I think that's just important. The more advocates that we have at the bedside is huge. I don't know if any of the panelists have anything to add on that, but.
Thank you for sharing that. And I know I said I was going to give other people a chance to ask a question, but it relates to what you just said. So I was wondering, you said that you had to change, and you have changed a lot about the way that you practice. And I was wondering if you could maybe expand a little bit more on that. Like what were the changes? What were the things that were going wrong? And what are the things that are working to fix them? And this is, I mean, this is for you, but also to everyone else on the panel.
Yeah, I can speak quickly about that. I think that, you know, in terms of kind of the reckoning that our country has really had to go through in the last several years, and I can only speak for myself, you know, I really had to take a step back and look and, you know, not like check my biases, right? First and foremost, recognize that we all have those implicit biases, and quite frankly, listen to the patient, because there's a huge campaign out right now that's put up by the CDC, and it's called Hear Her. And really the push is, you know, listen, stop talking, stop acting in a patriarchal manner, and listen to what your patient is telling you. If she has a headache, don't, you know, blow that off. I think we're very quick to, you know, judge people. And look, he who's without sin cast the first stone, right? Like I am guilty of that. You know, we are all have those. But I think I really had to stop and not pass judgment, but listen and really have it be more of a partnership. And we're all about team-based care. And Allison can talk to this too. It is shared patient decision-making. It is not me walking into a room and telling a patient what to do. That is not my job. My job is to provide her or them with their options and give my best medical recommendation. But ultimately, it is the patient's body, it is her choice, and she owns that decision. So again, it's not kind of that top down, it's more walking in as a team. Hey, we're all in this together. How can we kind of come to the best decision for you and your baby? Sorry, that was kind of long.
I think I would echo everything Dr. Snyder said, as well as just, I think, learning from my patients. We have so many patients that have a language barrier or are refugees, and just they don't ask the questions if we don't know to ask the questions. You know, people they come in, their blood sugar is out of control, they're not taking their insulin or they're not taking a diabetes medication. Well, they couldn't get it because it was sent to a pharmacy that is very far away from them, and they don't have a vehicle. And they're currently living in someone's basement with their other 4 kids, like sleeping on the concrete floor, like stuff that I don't think about on my, you know, day-to-day life are what people are struggling with. So I think kind of echoing the judgment of stepping back and what are the barriers that are preventing people from getting these things that they need. And also I think something that I'm not quite sure how to fix it yet. I'm working on it, but that people are coming in with trauma and with lack of trust in the medical system, and that I only may be there for that day with them. And how do I build that relationship and build that trust so that they know I do want the best for them, right? Like they know that the medical recommendations I'm making or the things that I'm saying are because I want the best for them and their baby and their family when they may have had really bad experiences in the past. And that's a day-by-day thing. I don't know how we fix that. You know, you work on it with every person, but I try to remember, like, I have an awesome job, but I go to that same job 3 or 4 days a week, right? They have however many, you know, 2 babies in their life, 3 babies. Like this is something they remember forever. I remember I can tell you every birth story of my 4 kids in detail, right? Like this makes such a big impact. So I think sometimes that to stepping back and saying, like, I may be in a hurry, or I may have 4 more people to see or whatever, but this is people's lives. And you need to take that time and build that relationship, even if you don't have the time to build that relationship.
I just wanted to add quickly, we've seen a lot of success with this relationship building with Corewell, and with all of the birthing facilities and our community members. because we've been able to educate on what physiological birth looks like, but also talking about when medicine is needed, and medicine is not bad. Talking about obstetrics, it's not bad. Like some people actually need cesarean sections, and there is a reason behind needing that. So just educating and affirming our clients that when medicine is needed, absolutely look at all of your options and make the best decision for you and your family, but know that it's not bad, and not to completely write it off. But we've also had the opportunity to have open dialogue and build relationships with other care providers. And you will hear my terrorist 2-pound Yorkie Coda and his boss. So I apologize for the squeaking. But we've been able to have some of these conversations with healthcare providers and really be invited to the tables and build relationships. Today is a prime example with a client that I just met. I was able to introduce myself to Dr. Snyder in person. We talked about being on this panel today. I also saw another individual from research that I knew, and I was able to have a conversation. But all of those little experiences, when we're being intentional about building relationships with care providers that are working within these systems, and then we can go out into community and say, these are trusted folks. These are folks that we know. I've been on calls with clients just to kind of see what's happening at the prenatal visit, and midwife Sarah Kent will just be like, oh, hey, is that you, Kiara? And I'm like, hey, it's me. And that brings so much more reassurance to our clients to know that they are safe and that they are in an environment where they know they are going to be taken care of. And I would just say when it comes to like changes in practice, those are some of the things that bring me happiness and joy. But I know we're moving in the right direction by taking those little steps, by really being intentional and building relationships.
Totally agree, Kiara. So for me, my biggest shift when I was a new doula, I felt like I failed if my client didn't get their birth plan, their wishes. And so there was a lot of onus. And I went through a different training organization and really shifted my approach to being focused on supporting the client where they're at, judgment free. And there is no onus on me for results. I'm just there for support, period. And it ended up being so much more collaborative. When I was a new doula, I mean, there were issues with doulas in hospitals and they were acting out of scope. So I was always very careful with my scope, but I was so thankful that Corewell took a positive approach and brought doulas into group meetings to get feedback and collaborate. And so I have set these standards for the doulas that subcontract with Gold Coast. I mean, they're all certified. They all carry liability insurance. They all have their own businesses and, CPR trainings. We do 3 required continuing eds per year. I bring in different speakers to train. Like last year we had a loss trainer come in. We've done this year was all about supporting plus size clients through pregnancy and the postpartum phase. And then most of the doulas on my team are VBAC certified. So we work with a lot of VBAC clients. And then we have done DEI training. So we brought in Sabia, the Black doula, and she trained our team a couple years ago, again, to make sure that we're as inclusive as possible. And then Pride came in and did a diversity training with our team and focused a lot, not only on Q&A, but also, using proper pronouns. And so trying to, again, be as open and collaborative as possible. And yeah, I do appreciate, all of the patient-focused care, like the shift in care has changed a lot in the last couple of years. So yeah, I appreciate where we're at right now. And the fact that Medicaid came to Michigan in January, it's a huge step. So for birth support, so needed.
I just put a quick, Crystal had a quick question about healthcare system allowing for that time to develop a relationship. And so Yeah, Allison and I are part of a very unique team at the hospital. So we're hospital laborists, right? So we both do 12-hour shifts. And I rotate through the OB/GYN services. She rotates through the labor and delivery floor, and then also down in our OB triage, which is kind of like a ED, if you will, for our OB patients after 20 weeks. And so the great thing about our job is that we are salaried. So I am not on an RVU treadmill, meaning that I don't get paid based on the number of procedures that I do. So that's kind of that value-based approach to care, which I don't know if that's gaining steam within the medical system. So the nice thing about that is that I can take as much time with my patients. My biggest constraint is how busy we are. So I would say that I'd love to spend more time talking with our patients, but unfortunately we just are pulled in a million different directions just because we're a very high volume based hospital doing over 7,000 deliveries a year, and our service alone does a quarter of those to, I don't know, yeah, almost a quarter. But yes, to answer your question, Crystal, there's a recognition by major hospital systems that we need that safety net, right? We need providers in-house 24/7 that are not RVU driven. And therefore, when you take money off the table, my decisions are not based on if I get to walk out the door at 5 p.m., right? So I make, in theory, hopefully, the right decision for that patient, taking money, taking time out of the situation, if that makes sense. But yeah, to clarify, Corewell does not make money on our service. But that's not the point, right? The point is to be that safety net. And their whole philosophy too is that, we're a lot cheaper than a $5 million lawsuit, right? So, and we've had phenomenal outcomes, I think, because we are there and we, can take appropriate care of the patient.
I think Crystal asked another wonderful question in the chat. If you could speak more about value-based payment.
Yeah, so value-based care is just the philosophy that I don't get paid based on, procedures, right? It's not so it's more just either you're salaried or you're based on patient feedback, which is great because then I'm not driven by the need. For example, if I'm a GI doctor and I get paid per endoscopy that I do, there's a huge incentive, right, to churn and burn, right? There's a huge incentive to do as many endoscopies as you can in a given day, sometimes sacrificing patient safety and potentially quality of care. So there's a big push for value-driven care, meaning, either salary people, get them off the RVU train, meaning they get paid for productivity, and instead incentivize them in different ways. So bonuses based on patient feedback, patient surveys, things like that, that collaborative care approach. I don't know, Allison, if you want to add anything to that.
Sorry, I was having difficulty with the mute button there. So I worked at an RVU place or an RVU based system before, and you essentially were being pushed to that. We really had to battle to have, because the midwives had longer visits than the physicians did. We were paid a third what they were paid. We were bringing in a third what they were. We felt like it worked out, but we were constantly getting pushed to do more, see more, right? Because that's how they make money. And if it's a business, so if you have a smaller place, especially, I think that's trying to keep the doors open or pay your CEO or pay whoever, they're going to keep pushing you to do, see as many patients as you can, which 30 patients a day in the office is not abnormal. And that's crazy. You don't have time to spend with anyone or educate anyone if you're seeing that many patients a day in an OB/GYN office. But that's pretty typical. And so that, again, we've seen all these bad outcomes because of that, because again, people are making poor decisions. People aren't being educated. People don't feel a connection and they don't feel safe with their provider, and they don't trust the decisions that they're made. They don't trust the advice that their provider is giving them. So we're starting, I think the pendulum is swinging back the other way, of having salaried providers, or recognizing that the number of patients you see or the number of procedures you do is not the measure of success. It's how many patients are, your diabetic patients aren't needing to go on insulin, how many patients aren't having heart attacks, how many, those type of health outcomes, I'm hoping is where our country is swinging.
Thank you so much for your answers. We do have just a few minutes left. So if anyone has a question that they haven't asked yet, feel free to take this space right now to ask it.
I have a quick question about, I know you mentioned that doula care is covered under Medicaid, but I was curious if it's covered under private insurance as well, and if that's something as like an OB/GYN and midwife that you are referring patients to doulas.
It's not covered under private insurance. Health savings and flex spending plans have been covering doulas, and I've been working on doulas and insurance my whole career. So we had partnered with an area company, Pioneer Construction, to add doulas to their benefits pre-pandemic. And then nationally, quite a few companies have added doulas to their benefits. PNC is one, Salesforce, LinkedIn. So again, it's not general insurance yet, but I think Medicaid is the first step to that. Dr. Snyder may know more on, this topic than, I would, but it is self-pay. So essentially to work with me, since Gold Coast does not currently accept Medicaid, our clients would either use a health savings, an employee benefit, or would self-pay.
Yeah, I think Kiara can also speak to this too, but I think that's what's so huge about Medicaid supporting doulas. We know that the outcomes for Black women in particular are better when there is a Black doula or some type of a doula at the bedside. We know that studies have proven that. So I think that's what's so huge, is it's made it so much more accessible, right? Like, so if you couldn't afford a doula, it wasn't available to you. But now that Medicaid is covering for it, I think there's a huge push that hopefully that will lower those, maternal morbidity, mortality rates that I mentioned before. But Kiara, you can certainly speak as well to that.
Yeah, and I also put it in the chat because I didn't mention it during my time, is that for folks who are interested in training with our program, but also receiving services, it's done completely at no cost. We have funding from several different sources that really value the work that doulas are doing and know the need specifically for populations of color to have access to this. We are absolutely thrilled that Medicaid is here. While we know there's definitely still more work that needs to be done in making sure, again, that doulas are also able to continue to do the work and that it's sustainable. But Medicaid absolutely is the first step. And we're having conversations with quite a few different folks on how to make sure that, everybody has access to it. And I did just want to say a hello. One of our doulas is actually on the call, Ashley Miller, who trained with our program. But we're just excited to see these women come through our program to be able to provide these services and receive services. But again, it's completely at no cost, which is something that you don't see all the time.
And I was just going to answer the other, we absolutely refer to doulas. And these are usually the two groups that we refer to, which is why I think it's great that we have representatives here today. A lot of our patients come in knowing they want a doula. So sometimes that's, they come in asking that question, and they're great when they come in with them in labor, for me particularly, because it's so helpful for us. But also we have cards and things like in our residency OB clinic to give them, and pamphlets and such that we can tell them about doula services. So we absolutely are pro doula and promoting their use.
Okay, thank you so much for that answer as well. It is 8:16. So just to be respectful of everyone's time, this would be the time that we would end. If the panelists, if you guys feel comfortable sharing emails or contact information, if anyone else has any other questions or would just like to talk to you, get to know more about your work, if you could just share that in the chat, we'd really appreciate it. Of course, only if you're comfortable. And I do want to thank everyone else everyone who came to this to listen and to learn. Yeah, you guys are all amazing.
Thanks for hosting us. I really appreciate it.
Thank you.
Thanks, guys. Great to see you.
Thanks.
It's a wonderful
You-
discussion.
you'll-
Good to see you. Bye,
We'll
Dr.
see you
Snyder.
maybe in GR, your third.
Yeah. Bye, Allison.
Bye. Thank you.
Bye, guys.
Bye,
Thanks.
Kiara.
Thank you.
Bye, everyone. Thank you.
Thank you.
Great job, Roxy.
Oh my God, thanks, Luce.
Of course. I'll see ya.
All right, see ya.